Good morning and welcome to Envision New Mexico this morning, bright and early. We are here for Adolescent Health Initiative New Mexico, and let's see, we do have a few items to cover. Let's get the correct one here. We wanted to let you know, number one, that we are recording the session today, so please don't include any confidential patient health information during the session. If you do wish to receive CMEs or CEUs, we will ask you to announce your name and where you're from here in just a minute. If you don't have any audio capabilities, no mic, then you can use the chat box, of course. And if you are called on and don't wish to answer, then please feel free to say pass. So computer video, there's a little camera icon. Default is on the bottom left, although you do have power over moving that. So start and stop your video feed using that. You can change your camera or your camera's settings by clicking the up arrow next to the camera icon. And additionally, with audio, computer, microphone, and speakers are preferred. Tends to use a very low bandwidth, so also mute and unmute by clicking the little microphone icon. It's a very old school looking microphone. Change microphones or mic settings by clicking the up arrow next to the mic icon. If you are using your telephone, please mute your computer mic and speakers if you're using the phone to avoid feedback loops and echo. Don't place us on hold if you're using the phone, or we'll hear all your hold music, and so will everyone else. I can mute you if needed also. And Zach and I are both doing the support today. Our disclosure and accreditation statements are on screen right now. Those are required to offer you the CME, CEU certificates. We do offer case consultation reimbursements. We have a deal with Molina and Blue Cross Blue Shield Community Centennial Care. So you can be reimbursed for bringing your cases to us. We do have a session coming up in about a month or so. And so you can bring those here this semester, or we're doing another round next semester as well in the spring for our behavioral health track here at AHI New Mexico. So get in touch with me at this point for more information on that, and we'll get you all that information. The reimbursement numbers have changed, the codes have changed, so get in touch with us and we'll get you on a list to get you that information as soon as we have it. And now is your opportunity for roll call. Like I said, it is required to give you a CME CEU certificate. You can do verbal or chat. Let's see, and certificates, by the way, we send those out once per month, typically the second week of the month. Feel free to contact me if you have any questions about that, but that's typically how that works. And so when you have a sec here, unmute and please announce your name and where you're from, or use the chat box.
Catherine Mallion, nurse practitioner, PA, Roswell School-Based Health.
Great, thank you, Catherine.
Thank you.
Okay, and while we're waiting for any others to sign in, we'll just go around the room and introduce ourselves, except for our speaker, who will be introduced in a moment. So this is Kevin Whirling, Systems Analyst here at Envision New Mexico.
Zach Johnson, Health Education Consultant.
Hi, I'm Emma. I'm a social work intern here at Envision.
Hi, this is Maya Trujillo. I'm a quality improvement specialist here at Envision.
Bobby Sen, resident physician, second year at Pediatrics.
And I will go ahead and turn it over to Maya, our facilitator for today.
Welcome everyone to Studio Envision. This is the Adolescent Health Initiative New Mexico. It is our goal to bring you up-to-date information and resources related to the care of teenagers. Today we welcome Carol M. Pierce. She has her BSN, her MPA, and RN. Ms. Pierce has 30 years of experience working in the health field in public and private sector. She is currently the program manager for UNM school-based health programs, which provides integrated medical, behavioral, dental and health education and case management services to 6 Albuquerque public schools in Albuquerque. Welcome. Thank you so much for being here.
Great. Thank you. Thank you. Well, I'm delighted to be here, and we've got an intimate crowd, and with you, Catherine, the 5 of us. So I hope to make this as informal as I can so everybody gets what they need out of the presentation. And I am delighted to present because I think there's so many different parts about coordinating care for adolescents. So there's 3 things I hope that today that our learners will walk away with. Is 1, I'll be providing the process which we use through our UNM program, and we're out of Department of Pediatrics, the Adolescent Medicine Division, and we've got a very specific way that we coordinate care in our school-based health centers. So you'll learn about that. You'll learn about how we coordinate care externally, and I'll talk about that process. And then, of course, can't talk about care coordination and working with adolescents without talking about the barriers and some of the ways that we're trying to overcome those barriers. All right, so you never know who all is signed up, so I always want to make sure I provided a little context about our school-based health centers. And Catherine, there you are in Roswell, so you may have things to add to this. But how we really frame our services here in Albuquerque is we are one of the only sites where adolescents can get very specialized care focused on adolescents. It's youth-friendly. Our providers are trained to give specific care toward adolescents. And there's some core concepts that really we think of when we think of our school-based health program. And I do want to add that we're always place-based care. We're there on the campus of a school. If we're lucky, we're really inside of a school. Of all of our 6 sites, we are inside of a school with the exception of our latest clinic, which is Manzano High School, which we're in a portable, which we like to say out in the North 40. It's a 12-minute walk from administration to our portable, and we say that's if you're walking as an adult, not as an adolescent. But and I also want to say in this place-based care, there are many different models of school-based health centers. We specifically, our model is to only provide care to adolescents. We don't provide care to adults after hours or integrate that into our daily services. And primarily it's because of where we're located and the credentials of our staff. So most principals don't want adults walking in randomly in the inside of the school to get care. And the reality is with the numbers of students that we serve, ranging from a middle school that's about 400 students to our largest high school is 1,800, there really isn't the capacity with one medical provider, one behavioral, to then invite adults in to be seen. So just wanted to add that. So we're a team of multidisciplinary professionals. It's medical, it's behavioral, and it's the integration of those services that really, I think, is all our hallmark in school-based health centers, and I think school-based health centers across the state. I like to give an example of, in the last 2 years, we closed a middle school where we had provided services, I believe, for 5-ish years. And I think it was probably open somewhat for maybe political reasons. There was a lack of access to care. This was in the East Mountains outside of Albuquerque. And clearly, there weren't a lot of other health services around there. Medical, we just couldn't quite get off the ground. We struggled for enough visits, but behavioral health, off the charts. We dealt with a lot of crises. We dealt with a student suicide. But in spite of all of our creative thinking, working with school administration, we just couldn't get the medical off the ground. So most people said, okay, well, just save yourself some money, take the medical out and operate a behavioral health clinic. And if that was our model, fine, but we're not a behavioral health agency just offering that service. So I like to give that example, and ultimately we closed and then we relocated at Manzano High School. But the integration of the services are essential. And I'll jump down to a minute. I think why the integration is so key is because we do a universal health screening at every visit. So and I bet, Catherine, you do that as well there in Roswell. It's the student health questionnaire, usually done on an iPad. I think most people know that's built off of the 6 domains off of the American Academy of Pediatrics for physical health and nutrition, well-being. And so that gives one of the most comprehensive pictures of that student's health that then the behavioral and medical provider will develop a plan on how to address those. I'm going to go back up to my other point, which is our expanded services may include case management, health education, and then oral health. And that's been key for us because with the plethora of needs that our adolescents have, which we tend to serve, I think, a more high-risk population, these added expanded services, which we've advocated to have in our school-based health centers, have been essential to address the multiple needs of students. And then, of course, the core concept is youth-friendly environment. And part of the example I already gave is we feel like it's a youth space. We're not really necessarily inviting the community into that space so people wouldn't see their aunts and uncles or mom and dad there. So we try to really maintain a youth-friendly space. Catherine, can I pick on you and ask if you would add anything else to how you would define that school-based health model that I may have left out?
I think you covered most of what we do here. We do utilize the questionnaire, the ESHQ, and that's been very helpful for us. I've been working school-based health for this is my 3rd year, so I'm still learning the ropes here. But overall, I think the questionnaire is a very good tool.
Yeah, great. Thank you for adding. So I just wanted to highlight, we offer services in 3 high schools, 2 middle schools, and an elementary. Our high schools are full-time, and our middle schools and elementary are part-time. So I come from the place of that's the context of which I'm providing our examples today as the experience with those 6. So I want to just dive deeper into our integrated care. And so our medical providers will range from pediatricians, nurse practitioners, physicians, assistants, and just bringing the medical lens to it. And the entry point may either be medical or behavioral. There's not one right door in our program, and we really like to use that language quite a bit. Sometimes the door they came in was through case management services, and that might be a referral through the health and wellness team, which we'll talk a little bit about. It also can be health education. Our health educators, especially in our high schools, we do a comprehensive presentation to all 9th graders so they know this is a service available for you. That prompts more students than you realize to say, wow, this sounds like it's a safe place. And they come in for service. We really proudly display safe zone stickers. I think that's one way to really illustrate you're a youth-friendly environment, and we really make sure that folks know that we are LGBTQ friendly and have participate in training annually. So additionally, our dental hygienists and dentists, not as much referrals come in that way, but that's certainly a possibility. We've worked hard to integrate the consent for care for dental and medical and behavioral all in the same consent. It used to be a little separate that dental had theirs, we had ours, but again, in the eyes of the school and the eyes of a family, that coordination, they see us all as one. So we do everything we can to say there's no wrong door, and here's your simple consent to sign for services. And then we have clinical coordinators and medical assistants that really keep the operation going, do the front and the back office work. So I did include just a picture of that student health questionnaire because, again, that's often the genesis of a plan for care. And that plan for care is where we're ultimately leading our conversation today is how do you coordinate that care? How do you rally resources to make sure the students got what they need? So I included this slide just to illustrate, I think, at times the high-risk nature of the students that we see. So this is a combination of from our 3 high schools. It was from the results last year from our ESHQ. And so you can see ever had sex, it's a high range. If you compare this data to the Youth Risk and Resiliency Survey that comes out of CDC and the Department of Health, often you can see that our ranges are really higher if you just do the broad anonymous survey from YRS. So depression screen, a lot of our folks are having the formal depression screen after those initial PHQ-2 questions, which are embedded in the SHQ, and that was a lot of alphabets there. But I think we all know there's just a couple of questions that are that initial screening in the ESHQ that indicates, is there a tendency toward depression, that then the behavioral health provider wants to go deeper and do a PHQ-9, which is the screening. So we're having a lot of students with depression tendencies and anxiety too, I would say. And then here, ridden in a car with someone who is impaired, a pretty high percentage. I don't think I included, but I'll just say our stats, especially at one of our high schools, on the range of students we see that identify as LGBTQ is exceptionally high over the state average. And we really, in fact, we were at that school yesterday talking about why do we think that is. At that particular school, we have commandeered a classroom inside of the school where our case manager and health educator are doing some of that initial screening with students. They're definitely a safe zone, and they're sending those referrals over. And at any given time, you can see 20 or 30 kids walking through there on a daily basis, maybe getting an HIV screen, which we do, given we're following the American Academy of Pediatrics guidelines on that. So I think that kind of connection with students is really making us a friendly environment and prompts a lot of referrals over there. But I wanted to include this just to show, again, a high-risk population with lots going on. Catherine, would you say in Roswell or anybody else in the room, is that your experience as well, just seeing a fairly high-risk group?
Yes. We have a lot of behavioral health issues. Our counselor here is always very busy and is always called out to other middle schools for consultations or emergency consults.
Yeah, great. Thank you. All right, so I'm going to move now that we've kind of set the stage of what place we're talking about, where we're doing our coordination of care. So I'm going to break our discussion down into internal and external care coordination, because the benefit of a school-based health center is there is a richness, because we're located in the schools, about how we do coordinate that care. So the starting point is consent. So here we're talking about our internal coordination. So I included the language on the slide of what our student consent form says. And basically that parent is giving permission that you can coordinate with other healthcare people, mental, dental health, and the school health professionals for purposes of coordinating care, program evaluation, and quality assurance. That language is key, because with that, then that opens the door to a lot of coordination within the school, in the school resources. So back to internal coordination, school-based health, we have a consent. So the first thing that's going to happen is the warm handoff. And I think we love to use that language, and it's great because the medical, behavioral, sometimes health educator are all there in the same space, and they can do a kind introduction. Hey, this student, la, la, la. Polly, I'm going to have her set up an appointment to talk with you. So that's what can happen. I think it happens some of the time. I think oftentimes people are pretty busy, and it's just if they've run into each other in the course of it, or they can intentionally do it. wrap up, which happens in every school-based health center on a weekly basis, is probably the biggest mechanism, I think, to internally coordinate care. And so for those in the room, and Catherine, I've got it there on the screen, you may use something similar. I brought the sheet that we use, and it's just simply identifying and creating an agenda on what are the students that we're going to talk about today. We tend to do wrap up when we have our adolescent psychiatrist or child psychiatrist in the room, because that's often where we're needing to coordinate what is the medical provider seeing, what is the case manager seeing about a student, behavioral. So students are identified, and then from everybody's perspective, they're talking about what they think the plan of care should be. This, we document it on this wrap-up form and keep this because often there's follow-up or more appointments that need to be made. The way we want it to work, but it doesn't always work this way, and I'll be curious, Catherine, to ask you. So when we're in wrap-up, we're all covered under HIPAA. So we all know that's the Health Information Portability Act that really protects students and the information. So this is the place that we could invite a school nurse in, invite a school provider in, invite the school counselor in to also add perspective on those students that we've identified on that agenda that day. When they come in, they're signing confidentiality statement, and they're really, now they're part of our HIPAA world. And going back, again, we secured the consent to do that kind of coordination up front. That's just such a key point. Catherine, do you do wrap up there at Roswell, and do you do it differently?
We use the what we call huddle. We review patients that are on our schedule for the day and see what we need to prepare for their visit. However, a lot of our students either don't show or we have a lot of walk-ins, so that kind of changes our approach.
Okay. And I'm glad you brought up huddle. We encourage a morning huddle, which that's a really good point, because that can begin a little bit of coordination internally there. That somebody, you're going to see patient X, and then that might prompt the behavioral to say, oh, wow, yes, I saw them. I want you to take a special note to look at X, Y, or Z. Sometimes I think our huddle takes the form of, wow, we have 15 patients today. It's going to be a slamming day. We're going to do 3 IUDs, so we've got to do la, 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 to get everybody kind of all the balls in the air kind of aligned. But I'm really glad you brought that up, because I think it can be an initial point of care coordination as well. So still on internal coordination at the school. So the health and wellness team, which in our school district, Albuquerque Public Schools, it's a requirement to have a health and wellness team. So that is a school committee staffed by school people, and usually it's school counselors, it's the school nurse that are there, and others, sometimes the special ed social worker, and those kinds of resources are there at the table to identify students and staff those students. Meaning staff like a case consultation. Sometimes they may pull up grades. They may say, look, Susie is failing in all these classes. What are we going to be doing? We've worked really hard over the last year, but I would say it's still a work in progress. This is a really important place where at least one school-based health member goes to receive referrals. So I've got our form up there, and I'll pass it around. It looks like the wrap-up form, but very distinct. So when we go into HOT, we've signed a confidentiality agreement. And I would say in the past, we might have had a bunch of school-based health center people go, including our medical provider, including behavioral. The risk of that is then you begin talking about that student, or you begin talking about, oh, well, we could do boom, 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 boom. But what we may or may not know, do we have consent? Because we don't know who's on the docket. on our wrap up, we know we're going to talk about Susie, Carl, we know what we have consent. In a hot, you don't necessarily know that. So what we've been trying to move toward a model, not rigidly, but to try to be clear that let's send somebody. The best person may be the clinical coordinator who knows the schedule, who knows, yeah, our behavioral health provider, yeah, we could get that student in and can simply get a referral. And I may not have included our referral form. I apologize, Catherine, I don't have our referral form. But our clinical coordinator will take this referral form into HOT and will begin filling it out there. And all of our school partners have this referral form. That keeps the lines of HIPAA and FERPA. And I think we all know FERPA is the Family Educational Rights Protection Act. It's the HIPAA for the schools. And so the health and wellness team is guided under FERPA. We want to be really careful on care coordination. That's the take-home point. Does it mean that our medical or behavioral providers never go to HOT? No, it's an initially good place to build relationships. But I think over time, we're realizing that may not be the best place for folks to spend time. You just got to take the person who can receive the referrals and move on, because we may not have consent to talk to about the students. Any questions about that? Well, I will say we struggle with that definition. We've really shifted it over the years. And our school partners really understand and really do see it as a school-driven meeting. And we shouldn't be the lion's share of the people there. Yeah?
Do you ever encounter difficulties with families understanding maybe what they're consenting to, or if it's just one of maybe tens of forms they're signing?
Oh, absolutely. Are you a parent? Okay, but that was asked as a good question, like a parent, because, so as we all know, you go to school, sign this stack like this. So we consider one of our most important times of the year is school registration, and we call it all hands on deck. So in a course of about 2 weeks, we will generate over 5,000 consent forms for the University of New Mexico from parents. And we make a little game of it, if you will, on how many no's do we convert to yeses. So there's 3 boxes on the consent form. Yes, my student can get service. The second box is this language around, yes, you can case consult and share information. And the third box is, no, I do not want my student to get services. So whenever we get the no, we ask, may I have a conversation with you? And they say, okay. And we said, well, and we describe, do you have, they say, oh, I have a pediatrician, I don't need to go there. And we say, that is great. We're glad you do. But we're here, so you don't have to leave work. And your student can get the sore throat taken care of, or they can receive care right here on campus and not miss as much class time. Oh, and I would say for the most part, 90% of those we turn around. I haven't honestly completed the counts for this year. Last year, we probably converted 300 of the 5,000 just because we had the conversation. And then there are those parents that are like, nope, I'm working with my student on their healthcare, don't need it. And that's fine too. Now we'll get into another piece of this whole puzzle, which is confidential care, which is a whole nother piece of this care coordination piece, which we'll talk about. But did I kind of answer your question?
Thank you.
Yeah. All right. So we've talked about HOT. We've talked about wrap up. So now I'm still in internal coordination, care coordination. Well, I think our world changed when we adopted an electronic health record. And probably some people would say for better or for worse. I think it's probably overall better. So we use something called Power Chart. But that's made care coordination for subspecialty care a breeze compared to how it used to be with paper copies of records. So The benefit, and we are grateful to be part of a university system that has a lot of subspecialty care. So it is as simple as our providers see this student needs an ortho consult. They need to see a specialist in pediatrics. They're electronically doing that referral, and then they can track that to see when that student has gotten care. And that's where the two providers can also do some consultation. So that has made care coordination internally pretty easy. I will say the downside, and providers, especially providers that maybe grew up with a paper system, it's laborious. And I think 9 times out of 10 where our providers struggle is they want to engage with the student. They want to make eye contact and talk. They don't want to be going like this. And I think some people are better about and then doing that. Not everybody. And I think a lot of our providers struggle with that. So what do? They do laborious charting at the end of the day for hours. So that's the downside. The other downside is confidential versus non-confidential implications. So I think everybody is aware that by state law, students can access services on their own over the age of 14 for reproductive and behavioral health services. So aside from that whole consent form that we talked about, even if their parent checked the bottom box and said no, if their student came in and they're over, they're of age, they can consent for care. And then we have them sign a confidential consent form that they understand what they're signing for. But where does the provider document? They document back in PowerChart for that confidential care, whether it was behavioral or reproductive health. So what our providers do is in big red letters say, confidential care, confidential care. We've been assured by the university that when a parent comes to request records, that they don't automatically just download all those records, and we haven't had an issue there. We have the patient portal. Because of that, kids up to 18 are not allowed on the patient portal, also because it could violate that confidentiality with parents accessing their students' records. But we have had a few issues where now with meaningful use and now with other clinics printing everything out and let's look at the medication list, let's look at everything. They say, wow, what's on that medication list? Oh, you're on birth control pills. We had a recent instance, our clinic to another clinic. Fortunately, that student had talked to her mom about, Mom, I've made these decisions, of which we are always encouraging students to have a supportive adult in their life. Fortunately, that student had, because when they went to the other clinic at UNM, everything got printed out, which just showed that they'd been over at our school-based health center in spite of the confidential. So we've got a lot of conversations happening at UNM on how we really prevent and protect the confidentiality for adolescents. I think the confidential in red letters isn't the solution. So it's an IT issue, and a lot of people are involved in trying to figure that out. So linking back to our objectives, that is clearly one of the barriers that we're experiencing on care coordination internally. Catherine, I think you all use an electronic health record. Do you have some of those same care coordination issues?
My notes for confidential visits are, there's a tab on the bottom where I can click on confidential, and I'm the only one that will be able to open the notes.
Yeah.
My staff cannot open the notes.
Yeah. Yeah. I think and probably Maya, folks you're coaching, same thing. I think our FQHCs do the same thing, and have a special tab. So I wish ours had that. I think that would be easier. So it sounds like that barrier may not be quite as true for you all. So we've covered internal coordination. It starts with wrap up. It starts with a warm handoff. There's wrap up. There's HOT, and then there's the electronic health record. So I'm going to shift over here to external, and I guess this is where I put the referral form. So coordination with primary care providers, non-UNM, does happen if a student has a primary care physician. I would say that, and it would be a good exercise to go back through all of our consent forms to see how many students identify a primary care provider. In fact, I think that would be a good thing to do. My guess would be less than 20%. And I think sometimes, I mean, the parents would know because they're the ones filling out that consent form, but we just typically don't have, they either don't have a primary care provider. I think it's different at East San Jose Elementary, and that mirrors the national statistics. With younger kids with well child checks that are driven, the parents are a little bit more engaged, and I think immunization requirements drives that a lot. But then as you move to middle school, high school, it's just not as driven, even though there are some immunization requirements. So it's typically that coordination comes around a student with diabetes because they are seeing an endocrinologist, whether it's at UNM or someplace else, or asthma care. So it's specifically over at East San Jose that happens, more often than any of our other sites. And how our providers will do that, they will either make a call to the provider or the nurse MA to begin doing some of that care coordination. I think back in the day, we used to do more paper and we would send, we saw your student, and that is less so the practice as really reaching out, calling, and then making some notes in the chart that we've coordinated that care. What we do try to get is they may have requested if we've done an asthma action plan or they've done the asthma action plan. That's been one of the core ways we've coordinated with primary care providers, is to get their asthma action plan so we can have it at the school, both in our clinic and with the school nurse. And then sometimes these are primary care providers at UNM, and the referrals are made easily, again, back through the electronic health record. I think one of our really great, coordination happens because we have 2 clinics in the Southeast Heights in the International District. So I'm doing Albuquerque speak here. And we have 2 very great UNM clinics up there. We have a family practice clinic and we have a young children's health clinic. And we have made special attempts to connect with those providers. We've gone to their provider meetings, and we did that early on as we were in PowerChart, and they were very excited because they were already on PowerChart. We weren't, and just saw the real possibility of coordinating. I think we have had some barriers there around how the immunization records get shared, and we're all kind of relying on the state immunization registry, which is required for people to fill out. But I think the reality is it may not always be. So we're still working through some of those kinks. But some of that coordination among our own UNM providers has especially been great here in the Southeast Heights. So behavioral health. So we have worked very hard on external referral and coordination with behavioral health. And why? Because, and I think I heard you say, Catherine, this as well. I mean, a lot of our students have behavioral health needs. You may discover that through the entrance of getting a sports physical, but a lot of kids, it's a self-referral or a teacher referral for a behavioral health need. So we don't have the capacity to meet all behavioral health needs on site. We keep trying to move, and we are moving a little bit toward what we call a brief intervention model, which is really the mode we want to be in. We don't really want to be doing care for years and years with the same student. However, sometimes there are barriers that prevent that from them being able to access community service. So what I've got pictures up there is with the support of our case management team for every school. on the backside, and that's the second part of that handout, we've got a list of resources, behavioral, for every school. And these are getting updated because they have to get updated all the time because things change. But the idea is on the front side, and it kind of starts with our clinical coordinator, is when a student comes, I need an appointment, or the referral form has come through, is doing a bit of triage to see, are you currently seeing a behavioral health provider? And sometimes the answer is yes in the community, and we don't want to be duplicating that service. And it's part of why we developed this, because we found out we were either duplicating with the community or we were duplicating with a school therapist, a school counselor. So the questions on there, and I just highlighted a few on my slide, does the student have services elsewhere? And what's the acuity level? Obviously, if they are showing suicidal thoughts, we're going to do an assessment and follow our protocol around that. Is it an ongoing need that's been there? What are their needs? Do the services need to remain confidential? That drives a lot. Some of our behavioral health agencies in town, in spite of meeting with them, have said, we will always contact a parent. In spite of our efforts of trying to say, well, there's state law that allows a student to access those services, some agencies aren't necessarily complying with that law. So we tend to know which ones that we've developed some good relationships with and we haven't. Does the student have insurance or not? I mean, the reality is if somebody does have private insurance and they could access resources out there, and maybe it wasn't a confidential service, we're going to try to use our resource list, I'm going to pass these around, to get that student care. But this is where, what are we doing? We are helping coordinate that care, but we're trying to build the health literacy for that student by giving numbers, names, and following up with them to have them help make the appointment. If a student is uninsured and they're uninsured and don't qualify for Medicaid, maybe because they're undocumented, it drives a lot. And they're a priority for us to see because there aren't always a lot of resources for them to get care. So we have been working on this external coordination with behavioral for a while. We're really trying to build our muscle around it. And what's key is having the relationships with our behavioral health agencies. Part of that is working with our school, so some of those agencies can get memorandums of understanding and provide care on campus. So it's not New Day, All Faiths. All Faiths is a fabulous agency that we have here in Bernalillo County, and they are willing to come to our Manzano High School and do place-based intake, which we will give them space in our clinic, the school will give. That helps out tremendously to help build the capacity. So I'm going to pause because I feel like I was doing a lot of talking, and that one, unpacking this external coordination for behavioral is kind of huge. So let me just pause and see if there's questions. Did it make sense, or is there something I could clarify on that?
It's good.
Okay.
Yeah, I think it makes sense.
Yeah. Okay, thanks. Yeah, we just don't have the capacity to do it all. And I think at the top of that, you'll see we if you flip it over, we said, whose crisis is it anyway?
Mhm.
And we had to put that on there because at times we felt like we were a mini emergency room.
Mhm.
Because people know we're a safe place, so they're coming, I need help now. And so we're really doing a lot of work on de-escalation. Let's unpack for that student what the need is. Do they really need to be seen today, or what else is going on? And that's what is driving that whole handout that we've got. We put this in place last spring, and I think it's making a difference. We're in the process right now of developing a transition plan for our case managers because of a loss of a funding source. And so this particular tool is going to be really critical that our clinical coordinators, the MAs, everybody really understands how to work this.
Do we have these forms available online that we can download?
I can provide them to Kevin. Kevin, you?
Yeah,
Or-
so this is Kevin. Yeah, we don't have them up currently, but yeah, if I can get them from you.
Yeah.
Carol. What we can do, Catherine, is we can put them up on our website, same place where you registered for the session and probably downloaded the slide set. We'll put them up there and they'll be there perpetually. And also for anybody we want to be able to watch this on Moodle, which is our asynchronous platform. And all of our past sessions are on there as well, Catherine, if you're interested.
Yes, thank you.
Cool. So we should get you signed up for that. So we can have those available for download on Moodle as well.
Thank you.
Great. So, questions. So I think our objectives were to talk about the process to coordinate care in a school-based health center, and we talked about both internal and external, and then we talked about externally how we're care coordinating and some of the barriers. Questions or
I
discussion?
have some questions.
Yes.
So you talked about early in your presentation about one of your school-based health centers, the clinic is off-site,
Yes.
kind of.
Yeah.
Does that make a difference in the flow of students coming in or not coming in? Have
That's
you
a-
noticed that?
That's a great question. And I'll say that's Monsanto.
Okay.
That's where we're at, a 12-minute walk at an
Yeah.
adult pace.
Right.
You know, the answer is no. And
Okay.
we joked about we needed golf carts and we were going to put a golf cart in our budget to get, which has not been needed. The students find us. I describe opening a clinic there as ripping off a Band-Aid on a scab because, that's kind of a bad nursing analogy, I'm sorry, but no, it has been very high acuity and the students find us. We have our medical provider only works, she doesn't work full-time, and so we are really having to close the clinic. I won't have anybody there by themselves. A, that's not safe, and B, because students just come.
Mhm.
They just come, and they're often in crisis.
Yeah.
So that hasn't been a problem. I do think the classroom that the school gave us, where we have case management and health ed, and it's a very youth-friendly environment with food and with couches and with HIV testing and information, that conduit definitely helps. But as of almost to the day, we opened a year ago, and it's been fast. So that our worst fears did not play out there.
Yeah.
Other questions?
I have one other one.
Yeah.
Or
Yeah,
actually, I have
please.
two. So you talked about your health educators and how they work in your clinic. Do you guys do any peer health stuff, like peer-to-peer health education?
Yes. In fact, Albuquerque High does a lot of peer-to-peer. They got a grant from, I want to say it was Planned Parenthood,
Okay.
to do a peer-to-peer education. And we've had those peer educators present at Head to Toe.
Oh.
These are really great rock stars who are out there talking about, and actually talking a lot about contraception with that Planned Parenthood. So we found that as a really good model. We haven't done that at our other high schools or middle schools. I think it's a matter of getting the right people to do it, but I think it's a great thing to do.
And then my last question, so you talked about the consent or the parent permission and confidentiality. Can the students give their parents, can they sign off for their parents to be able to access their records if they wanted that for some reason? So you said you encouraged them to have someone that they could talk to, an older person in their life, but can they also say, well, I think it's okay if my mom comes and asks for my charts, do they have that option?
That's a good question. Since we never provide the charts at the
Okay.
local level, we let that go through medical records. I think if a student did that, I think we could reach out to medical records and try to help facilitate that for them. I haven't heard about that. Have you had experience with that?
That kind of sounds similar to signing a release of information, like as though you were a patient,
Yeah.
and we were coordinating your care with another facility.
Yeah.
To get your info from them, you would need to sign a document saying it's okay for them to let me know and let me see specific things. I imagine it would be handled similarly since it's kind of an analogous process.
Yeah, I think that, I think that's right. That makes sense.
I have a question.
Yeah.
So we've been talking a lot about youth engagement and care coordination, and I'm just wondering what do you think is the best way to get youth engaged in their own healthcare?
Yeah, well, I think by raising the peer-to-peer education, I think that is so key, arming peers with information. I think that helps when it's coming from another student. And are you thinking specifically around care coordination or just engaging?
That's kind of what we've been talking about, but yeah, just engaging
youth.
Students to just know more about their health and take action. Because even I think about myself, and
I know
probably didn't know my primary care provider's name until I was a lot older, having to call my mom all the time to do that.
Yeah. Well, I think there's things we can do on a clinical level that we try, but I think the reality is sometimes it's such a, we're kind of trying to meet the need and trying to address the appointments because we're trying to get language. We always are asking students, do you know your health insurance? And we often have students say, well, no, I don't have health insurance, I have Medicaid. And then that opens the door. Then we say, well, no, that's great. Medicaid is health insurance. And so we try to work with all of our staff to say, use those teaching moments.
Okay.
But one thing I really love is we have a handout here that we'll use over at Hayes Middle School here in about a week because they're a feeder to Highland. And so we've been asked to come to their health fair, and we love those opportunities because that's when we start those parent conversations about resources at Highland. And so we use a poster called 18 Things to Know Before 18, and I think Maya's probably used those. I think that is excellent because it's about, do you know your primary care? I think that key checklist, and it's done written in a very fun way. We will have a lot of those handouts to really give folks and let them know. But I think we haven't done ever any specific class or anything like that. I think peer education's key, and then how we interact.
Right.
I think the other thing I've noticed, and it's more about, it's about coordinating resources. We had a really a hard year last year at one of our high schools, and there had been a suicide. We had a student that had been raped, and as sad as it is, rape is fairly common in the students we're seeing, and we talk a lot about what is consent. And I find those kinds of conversations and giving students language is really important because I do consent. And so what got prompted last year, and I really credit our staff and the inquiring minds of students, what came out of that was an extremely rich presentation done by students about consent and about rape. The school supported it. They had every 9th grade health education class attend. There were no adults presenting. It was 3 students that did it, and they talked about resources, and they did a pre and post survey. They did get a little guidance from our staff on SurveyMonkey and how do you use that. And, I sat as a fly on the wall watching and heard a teacher come up to say to the the school-based health person I was sitting next to, oh my gosh, this is the best thing we've done. And why? Because it was students. But it was born out of a need, a conversation that people were kind of spinning around like, oh my gosh, something bad has happened, and turning that into a more knowledgeable base. But I think our role was to support the students, give them information, look at their PowerPoint, do what we could. But sometimes it's born out of a bad experience that.
I know for myself, 3 things that I've noticed with patients being engaged or taking on their own health, so to speak, has been patients that are entering adolescence that have a lot of chronic needs like type 1 diabetes or various autoimmune diseases. They really know their medications, they know their dosing, they know their timing, they know their allergies, they know their medical history, their surgeries, their primary care, the different specialists they see. And I agree, I think it has born out of need to do that. And then the second thing I had seen primarily with the school-based health clinic has been females tend to have a lot more initiative with their healthcare, I think primarily because they encounter a lot more health considerations sooner than males might otherwise. And to that end, I think males kind of join the spectrum when they have a vested interest. For example, a patient who's overweight or is really interested in athletics or bodybuilding or their image, they're interested in ways to lose weight, ways to build muscle. And so I think in those 2 regards, or 2 brief examples, it's when the patient has a vested interest, when they have something to gain or lose, then it's self-motivated, it's intrinsic or organic, and they want to learn more, they want to be involved with that. And the last thing I've seen has been kind of the other end of the spectrum, where maybe it's an otherwise healthy child, they don't really have things they see a doctor for otherwise, and they don't really have issues outside of school. They don't really want to do the private physician interview as much. They maybe are all too happy to defer to parent or, well, I don't know, and I've never really done anything, and I think maybe because they haven't had to. That's speculation, but it's kind of an odd dynamic there, where maybe the patients that need it the most kind of get out and acquire it, or they take it on to continue.
Right.
And those who don't really have the external pressure or driver or the internal desire, not so much.
It's interesting. Thanks for sharing that.
Yeah. Thinking one option I think we've tried to do is encourage students to bring, sometimes they'll bring a friend in, maybe when they're getting an Explanon, or encourage them to bring in their boyfriend. And it's a great way if they're making decisions on contraception. And we find that okay. If it's okay with the patient, it's great to have another adolescent set of eyes and ears who could learn something and be part of the process.
That's very interesting. Thank you.
Yeah.
All right, it looks like we are out of time. We're about a minute over. Catherine, just wanted to let you know we do have a survey that I'm going to send to you in an email. We're having a little problem with our recording computer at the moment. These updates are always fun when they require you to restart with no
warning,
warning or options. That's what we're experiencing. So I'm just going to email that over to you since you're our sole participant. If you could, what that does, it is anonymous, although obviously you're the only person. So be nice. And great. So Zach was able to send that out. Awesome. So it's in your chat box. I'm going to email you some other things about Moodle and otherwise. So I'll let you go. But again, thank you, Carol Pierce.
Thank you
for your presentation.
Thank
you.
We'll go ahead and sign off. And Catherine, if you have any questions, respond to my email, and we'll get you all set up.
Thank you. And I do have Moodle. I did sign up for that.
Oh, awesome. Okay. So you don't
Thank
need
you.
information on that. Okay. I'm your support person for that as well if you need anything.
Thank you so much.
Thank you.
Thank
and
you.
We're going to go ahead and sign off. Thanks. We'll see you next week.